talk is about thymosin and how it is useful in reproductive or repeated implantation failure and repeated pregnancy loss.
Rutvi?
So when we talk about definition, as like most of the talks start, which I'm not going to spend much time upon, but one concept I would like to float, that implantation failure and after implantation miscarriage or rejection is part of the same spectrum, because the endometrium has to function from implantation to delivery. So when we have a good implantation, good placentation, we form a very good placental reserve, which is capable of growing the embryo from a very tiny 110 micron size to a well-grown baby of 2,500, 3,000 grams. So we can appreciate that the growth is very exponential. That is from few nanograms to few thousand grams. So obviously the placenta has to have that amount of capacity to support, because as the baby keeps growing, the blood requirement of the baby increases. So this endometrial function, if it is significantly or very severely affected, then implantation doesn't happen at all. If it is little bit better, then implantation happens, but it doesn't grow, which we call it as a pregnancy failure or abortion or miscarriage or RPL when it happens many times. And if this placental function is inadequate in the third trimester, we call it as placental insufficiency, which essentially has two components. One is the fetal side, where we see oligohydramnias, reduce abdomen circumference and growth retardation, etc., etc. And by about 24, 28 weeks, the fetal supraadrenals are fairly developed, so it can send signals to mother, ki, okay, I'm getting less amount of blood, so you increase your blood pressure. And then we have the maternal component of PIH or pregnancy-induced hypertension. So I think the whole concept here I want to put that endometrial function is not just restricted to implantation, but nurturing the pregnancy from implantation to delivery. This is about prevalence. These are different factors. What we are looking at is immunological factor today, specifically. Now, RIF, we can have maternal factor, embryonic factor. Let's not get into the embryonic factor because it is a subject in its own. In maternal, again, there are amniotic anatomic factor, endometrial receptivity factor, thrombophilia, and immunological factor. So now, the anecdote which I use when I explain to my patient that what is immunology of pregnancy. So the simple layman language explanation is given that we all have been in our mother's womb. Obviously, that's why we are here. So mother has nurtured us for 9 months. Now today, if we decide to give blood or kidney or liver or whatever to our own mother, it may not match. And many of the times, the blood group of the mother and blood group of the baby are different. So when they are essentially unmatchable, what happens, that mother does not reject this embryo for 9 months. So that's a practical thing which we all see, but now we have to have explanation for that. So let's see what happens in our body when we get any antigen. An embryo is a type of antigen, and every time a new antigen comes in. So, what studies have so far shown that, sorry, that when there is an increased immune activity with cytokines, and when there is a decreased immune suppression of the cytokines, then the miscarriages or poor placental or endometrial function happens. Now, we have to have both these systems. So, as we know, this is what happens, that increased activity and decreased suppression, this is a balance. Now, high activity of T cells is expressed through cytokines, and when we have more cytokines, then we have a poorer outcome. So let's look at what this cytokine balance is. So if we have to look at the basics of our immunity, one can say that our immune system is made up of lymphocytes. So we all agree with that. And these lymphocytes are again mainly of two types, T lymphocytes and B lymphocytes. So T are the ones which produce cytokines or cytotoxins, which are essentially there to deal with unknown antigens. Those antigens which we have already exposed to, we form antibodies and we react through B lymphocytes. So that's what one of the classical recent example, which is quite relevant, is of COVID. So COVID was an unknown antigen for all of us. So that virus went in and our body reacted it either with cytotoxin dominance response. When the cytotoxins were secreted in a very high amount or high quantity, we labeled it as a cytokine storm. And then we know these cytokines are not specific to any particular cell. They are in general toxins. And that's why when we have very high level of cytokines, not only the pathogen, but also our own body cells get damaged. And that's why we saw people with cytokine storm having damaged lungs, because lung has been the primary port of entry for COVID virus. But not only lungs, it also affected other organs, almost whole of the body. There have been reports or doubts or clinical suggestions that it caused increased thrombosis, mainly microvascular thrombosis. And that's why cytokine storm is more in some patients. Now, in the same pandemic or epidemic, we saw that some patients responded with dominant B cell response and relatively less amount of cytokines. So the clinical presentation of this is very evident in our surrounding or in our society, that if we consider a family where two people are affected with COVID at the same time, one responded through high cytokine levels or cytokine storm. So his body organs got challenged or damaged, and for which he had to be admitted in the hospital, maybe ventilated, or may not have survived. But at the same time, another family member who also contracted COVID virus at the same time did not have cytokine storm. So that person was much less symptomatic, much less requiring medical treatment, or was treated just at home or had minimal symptoms. So why these two different responses we have seen? So this comes to the conclusion that we all, as an innate people, have a tendency to respond to any antigen with either T cell dominance or B cell dominance. So I think this is a first concept I would like to put through, and for us to remember that all of us are made up of different type of immune responses, either T cell dominance response or B cell dominance response. Now, extrapolating this information in our reproductive sciences, that is RIF or RPL, we can say that those women who are having T cell dominance will have poorer outcome, and those who have B cell dominance will have a better outcome. Now, clinically, how do we diagnose this? So there have been a lot of exhaustive tests we have been doing here as well as in my center in London. And we have come to a reasonable conclusion that a simple test, which is called peripheral blood NK cell, which comprises of CD3 representing T cell lymphocytes and CD16.
Dr. Ranjit, I'm sorry to interrupt.
Yep.
Am I not seeing the slides moving, or is it? I mean, for me, it's still stuck up at increased activity and decreased suppression.
Yes.
Is it still there? Yeah.
The slide is still there.
Okay. Thank you so much. Yeah.
But what I am trying to do is to have a minimal slide.
True.
And maximum talking.
Agree. Appreciate that. Yeah.
Obviously, we will have some time for questions. So
yeah, definitely.
I'll be finishing quicker.
Yeah.
So the second point I would like to emphasize and to be noticed is the diagnostic test is peripheral blood NK cell CD3 and CD1656. CD3 representing T cell, CD1656 representing B cell. We can also check one of the inflammatory marker called TNF alpha. So if you do these two tests, we get fairly good idea. And I would like to underline the word fairly good idea, because there are lots and lots of different types of T cell markers and B cell markers. Like we have CD3, we have CD4, CD8, CD16, CD1656, bright, dim, TH1, TH17, TH2, so many things. But I think this is, as a primary screening, this is what is important. So now let's see, this is a theory. Now let's see what people who have done some research in this area, what they have found out. So just to summarize, I have got some conclusions here that ILT4 plus and DC means dendritic cells play an important role in the maintenance of immune tolerance during pregnancy, probably through induction of FOX3 and T regulatory cells. So these are induced, that means increase, a process which is impaired in recurrent miscarriage and recurrent IVF failure. That means this induction of FOXP3 and T regulatory cells are not recruited, or if they are not recruited, then we get this RM or RIF. Then this is another study which shows that modulation of immune system in RIF patient is shifted to inflammatory responses as NK cells such as TH17 signaling pathway and TLR signaling pathways are activated. That means we have more amount of TH17 cells, which are again representing the T cell activity. And that's why there is a more inflammatory response. So I think this is also a study which is supporting in line with what hypothesis or concept we started with. We can measure Th17 also, and like we can measure so many other cells, but that increases the cost, like how we have discussed with Dr. Shivani ma'am's talk, that person like me is in India is practicing in a grade 2 or grade 3 city of Nasik. Now, this is another thing, that imbalance between CD1656 dim and CD1656 bright, that is T cell and B cell, uterine NK cells may have important functional implication in RIF and could be used as a diagnostic marker. So again, it is telling us that, okay, you measure CD1656 in blood. So they should be normal condition, they should be high. And if they are low, that means their B cell response is low. CD3 and CD1656 always will be found in an inverse proportion, because we have to maintain the total immunity. So if the B cell immunity is less, the T cell will be more, and vice versa. So for pregnancy, the conducive environment is when the CD3 is low and B cell response is high. That's another study. A combination of higher pro-inflammatory Th17 and exhausted T regulatory cells and lower T regulatory cells and exhausted CD8 T cells may coexist in the peripheral blood of women with RIF. So what this tells us, that when there is pro-inflammatory CD17 is high, T regulatory is low, then obviously CD8, which is again a B cell marker, we will have a poorer pregnancy outcome. This is another study. Cytokines play a role in controlling endometrial, decidual, and cytoblast cell inflammation, and therefore defects in the expression of cytokines and or their receptors are likely to result in the implantation failure. So this is nothing new than what we have discussed or what we have hypothesized. But this is to say, okay, the hypothesis is one part, but when people have actually done some work and found out the results, it is the same. Now let's come to practical thing, that we get a patient who has had recurrent implantation failure or recurrent pregnancy loss sitting in front of us in the clinic, and what we do today. So these are the few of the interventions I have listed. So after I've finished, you are welcome to add any more things which will help me to enrich my knowledge as well as update this slide. So let's look at intralipids. So intralipids acts on elevated NK cell activity. Now, what is the activity of the T cells? That to produce cytokines. Now, what is intralipid? So intralipid is nothing but a solution of essential fatty acids. This was initially manufactured way back in 1962 by Frasinus Cabby in Germany as a total parental nutrition fatty component of TPN. We know that when we need to have nutrition, we have to have carbohydrates, proteins, and fats. So this was covering the fats. Now, why this works with the IVF failures? Because this is made up of two major fatty acids, which we know as MUFA and PUFA, that is monounsaturated fatty acids and polyunsaturated fatty acids. So these mono and poly fatty acids are essentially very good oxidative stress scavengers. So when you have more inflammation, you have more oxidative stress, and this will neutralize that oxidative stress. So this was initially thought by Jonathan way up in Nottingham, and then he called upon patients who had more number of IVF failures. I think it was more than 4 or 6, and then he got good results, and since then it has been used. So essentially it is neutralizing the oxidative stress caused by the inflammatory markers. Tacrolimus. So it acts on the elevated TH1 TH2 ratio. That means it reduces the TH1 and increases the TH2 immune response. Now that's why tacrolimus is also seen very commonly in all transplant patient. If you come across any patient with liver or kidney transplant, you will rarely see a patient without tacrolimus. Almost 90% of them are on tacrolimus, because again that is to suppress the host and graft reaction. So the rejection chance of tacrolimus goes down. There was a concern, or some people still have concern about tacrolimus, but the American Transplant Registry uh, analyzed 732 or 738, either of the two, I don't remember the exact number, patients who had some kind of organ transplant, were on tacrolimus, conceived, and went on to deliver. And these patients have healthy babies, so tacrolimus is considered safe. TNF alpha inhibitors like Humira and so many other products again work the same way. That's why we initially discussed that okay, let's measure TNF alpha. If it is a high thing, that means it is one of the markers secreted by the T cells. Now, the problem with TNF alpha inhibitors is they are fairly expensive. One shot of Humira cost, I think, about 35,000 rupees, which I inquired 10 years ago. The cost might have gone up or down, but that is only cutting the branches, because we are not really suppressing the whole T cell activity. And T cells on the other side do not produce only TNF alpha, but other inflammatory markers as well. And these TNF alpha inhibitors will inhibit only TNF alpha and not the other inflammatory or T cell chemicals. IVIG, yes. So what we are doing with IVIG is immunoglobulins, that is antibodies we are increasing so as to correct the balance between the T cell and B cell activity. Hydroxychloroquine, we know it is also very good anti-inflammatory. It is used in many of the inflammatory, may it be autoimmune or antibody related things. We also know that this was used in cytokine storm associated with COVID. There was a famous phone call by Donald Trump to India that send us a shipload of HCQ. Then endometrial scratching, again, there was a thought that endometrial scratching will increase the B cell activity there, and then that will improve the outcome. But like many things in IVF, which come as a fashion and go away, like nowadays we don't consider much about the time lapse, or if we have to discuss about IMSI, so not many people are talking about it. So these are the fashions which come and go, because we as clinicians, we have uncertainty how to tackle these patients, and there are many attempts which have been made with good or commercial intentions to elevate our anxiety or problems when we are dealing with such difficult cases. So now let's bite the bullet that how about measuring the thymosin level directly? So this is what people have done. The decreased maternal serum thymosin alpha level may be associated with periconceptual endocrine and or immune disturbances preceding to miscarriage. This was found out. So now let's look at what is thymosin and how this molecule has a role in correcting whatever we have discussed. I think few of the people have their microphone on, so if they can kindly check, the my voice will be more clearly or audible. I do apologize that I have a low voice. I used to speak with a higher, louder voice, but then I got married, and since then my voice has gone down. So, anyway, coming back to thymosin, let's look at what thymosin is and how what role it has to play in this context. So, thymosin is essentially a hormone secreted by the thymus gland. One of the quality of this hormone thymosin is that it does not act on a target organ like other hormones which are produced by a gland at one place and they go and act at a different place, like we have seen with FSH, LH, estrogen, progesterone, thyroid, insulin, whatever. So what thymosin does is that it will influence the cells, lymphocytes, which are produced in bone marrow. Essentially, all lymphocytes are produced in bone marrow, but they get influenced or sanskarit in thymus, and they become T cells. And one of the important part of the T cell is the T regulatory cell, which should regulate the function of the T cells because we do need cytotoxins, we do need cytokines because that's the only way we can deal with a known antigen. Once we are exposed to a antigen, then we form antibodies, and that's what even world did during COVID. That initially it was unknown antigen, so we underwent lockdown. Then all of us got vaccinated, so we became known to the antigen, and now COVID is still there, but we are not bothered because we are responding by B cell response, and that's why we are not going through the cytokine storm. That's why we are not having any morbidity or mortality associated with COVID. So this thymosin is basically thymosin alpha is a synthetic thing of 28 amino acids. So it is a hormone made up of amino acids. So that tells us that it has a very good safety profile and it has no toxic effect on the mother or on the baby because you are secreted with thymosin anyway. Now this is a complex action. I won't spend much time on this. So this is a study which was done, a double-blind multi-center in COVID, and what it showed is was very interesting, and that's what attracted me to this molecule. And this was the first time in the world that thymosin has been investigated for recurrent implantation failure. So when I went through this, then I compared that what happened after thymosin alpha which were going. So T regulatory cells increased. It corrects the TH1 TH2 ratio. TH17 went down, PD went down, PDL1 went down, and this is exactly what we desire in the recurrent implantation failure. So all the things like T regulatory cells are low, as we have seen earlier. TH17 is high, which comes down. So then I thought, okay, we got this. These are the legalities which will come. Anyway, so what I did is that I called few patients who were having recurrent implantation failure or recurrent pregnancy loss. They got success. So total number of patients in initial trial which were studied were 114, 114. So all these patients were good endometrium, good embryo, and had more than 3 IVF failures, whether in my center or in other centers. But for patient altogether, they had 3 or more IVF failure with good endometrium and good embryo. So those were selected, they were called upon. 44% of them conceived with thymosin and 38% had intrauterine cardiac activity in these poor implantation cases. So then this data was submitted to DCG and then they got the approval. But this is in general about safety of thymosin, that it's available for a very long time, since 1979. It is US FDA approved. It is tried more than two and a half to 2,000 to patients. More than 2,000 published articles are published. Thymosin have been used in elderly patients also. So this is the certification by the government of India for it to be used. This was an interventional protocol which currently we are doing. We are doing a lot of work on thymosin alpha. So this is a single center 4-arm, that is 2 subgroup fresh and frozen embryo transfer, that is with which are randomized, parallel, double blind, placebo control. So this is a very high standard watertight study which we are doing. That's one part. This is a study protocol which got the ethics committee approval. So I won't go much in detail, but if somebody wants, I can very well happy to share the study protocol or whatever. So the dosing, what we have been using, the initial dosing was 2 ampoules alternate day, which was extrapolated from the pharmacokinetic and pharmacodynamic properties of the thymosin alpha. But then when I started implementing it in the clinical practice, it was difficult to explain to the patients. It was difficult to explain to the nurses. So, which turned out to a simple protocol, that 1 ampoule every day, rather than 2 ampoule alternate day, 1 ampoule every day. And probably the data is yet to be processed, but probably it gives a better result, if not the same. And it is management administrative wise, it is much more simple and easy. So this is the product overview we have already discussed. So thank you very much for allowing me to present whatever work we are doing. There is another study. There's another study we are currently doing is on dosing dose optimization of thymosin alpha. So for that we need to determine what the basic thymosin alpha level is, then how much thymosin alpha we are giving, and how much correction in the level of this thymosin alpha is happening. Because whenever we are talking about any hormone, like how we do a tailor-made dosing, say for thyroid, if somebody has a very high TSH, we give higher. We start with a higher thyronorm or with sugar. So I think the same thing should apply here. Now we got ethics committee approval. Thymosin level determination kits were not available in our country, so they were negotiated with a lab who specializes in delivering such manufacturing such kits. And I'm happy to share that a month or maybe a month and a half ago, the kits have landed in India, and soon we'll be doing the dose determining study, where we will take the blood, see how much thymosin level that patient has. Then when we give this 1.6 milligram, how much it will increase, what is the optimum level of thymosin in the body, which will relate to the clinical thing. So I think this will be a very remarkable essential data giving study, which will tell us that clinically so far whatever the results are quite encouraging. But this study will make it more tailor-made, rather than giving blanket 1 ampoule every day during endometrial stimulation, may it be fresh cycle or frozen cycle. So I think, like anything, when we find a new thing, we need to continue and evolve and fine tune it. So this is what the work we have been doing in Nasik in last few years. Apart from many other things, we do lymphocyte immunotherapy and a lot of stem cell work for endometrial rejuvenation. So we just completed about 115 cases of stem cell, but that we can discuss at some other point. I don't think that's a platform today to discuss. So yes, that's all regards and the work we have done from Nasik. So if there are any queries, I can try to answer.
Thank you so much, Dr. Ranjit, for such an elaborate and comprehensive talk on thymosin alpha. I think you have definitely given a very good overview. We all were keen to know about this because I think very few people are using it because of all the apprehensions, and you have cleared many, many doubts. And I would request all the chairpersons also to give their comments. Is Dr. Bindu Bajaj, sorry, yeah, Dr. Bindu Bajaj also, ma'am, you also can give. But I think would request because Dr. Rita Bakshi had to leave. So would like to hear and then maybe she can leave. I think she's left. Yeah. So Dr. Nisha and Dr. Bindu, any comments from both of you?
Yeah, thank you, sir. It was a very wonderful talk, and the bases have been cleared, which we were still, trying to sort out. One thing I always had this doubt in my mind that we do not know its impact on the embryo. So I have used thymosin alpha in few of my cases, and I also got a very good result. But the I usually try to stop it. Like the initial protocol also said to stop the last injection to be given 48 hours prior to the transfer. So I used to give it 48 hours prior to the transfer, and then after transfer I was not continuing this. But recently I came across literature where they are continuing the injection even post transfer also. So because I am still skeptical about this, that how far it is safe to use it after transfer, because we do not have any studies, we do not have any information. On the other hand, if we do not do, how will we know that, So still I am at a loss at this. Number two, I also believe that there is no uniformity in the grading of embryos and all, which is a basic problem all over. So unless until it has to be a true RIF, then only thymosin alpha may help, right? Because if it is like, we have done some embryo transfer done at some place, some other at some other place, and there was not optimum endometrium, it is not true RIF. So we cannot say that whether it was effective or not effective. So, any insights about the dose? How far should we continue? Because in a recent lecture by Dr. Gilmore, he said that actually the first trimester is pro inflammatory. So, the inflammation, whatever changes are happening, has to happen in that first 6 to 8 weeks' time. So, it is ideal to continue thymosin alpha for that duration.
Okay, so ma'am, you have raised two, 3 points, and I will share a slide which was actually done by a patient because they are very well literate and whatever. So let's get to the first point, that the safety of thymosin. Now, as we have seen that it is made up of 28 amino acids, so which is safe. It is, we all have thymosin anyway. So this is not a drug. This is not a drug, or this is not a new molecule. It is what is there in your body anyway. So when it is less, then we have this less T regulatory, higher TH1, higher TH17 kind of thing. Okay. So as I said that, okay, how do you determine whether it is less or more in your body? So we have to decide what is the normal level for thymosin preconceptually, and
Yeah.
then we correct it. So if you need a certain amount of thymosin in your body for a successful pregnancy, then in my opinion, it should be there throughout the pregnancy till the delivery part. If you have a thyroid patient or a diabetic patient, you won't give thyroid only till first 3 months or till embryo transfer, whatever. Currently, I'm using it till embryo transfer. Then, if the pregnancy test is positive, we give 2 doses a week till 12 weeks till the placentation is complete. That is mainly for the cost reason. Now, if somebody gives me thymosin at a reasonable or a affordable cost, I think I would use it till delivery.
But isn't it like, sir, progesterone? That once the placentation takes place and progesterone is produced on its own, maybe once the placenta is formed properly, this hormone support is also. That's why even if we are stopping it at embryo transfer, the pregnancy is continuing, right? We do not have any indication, barring those cases where miscarriage happens. We do not have any indication to continue throughout pregnancy.
Yeah, I mean, your question is quite logical, but what we have to understand that estrogen and progesterone, which we give externally, the production of estrogen and progesterone is taken over by placenta.
Placenta, yes.
Anywhere between 9 to 11 weeks, that's what the study says. Now, in which patient it is 9 weeks, in which patients it is 10, in which patient